This is the first question of our ECG question answer series. So let's start. A 50-year-old man is presented in casualty with complaint of having chest pain and diaphoresis associated with left arm pain since 4 hours. Apart from the feature associated with pain, there is no abnormal physical finding. So what does this ECG shows and what would you do? With regarding the symptomatic presentation, ECG is must in the casualty. In fact, in recent time, every chest pain, epigastric pain and dizziness must have an ECG in casualty. Come to our case. Let's see what his ECG says. Yes, it is the abnormal ECG. See, there is a normal ECG I have placed besides this abnormal ECG. So we can compare the ECG. So there is normal sinus rhythm, number 1. Number 2, normal axis. Okay. There is ST segment elevation in lead, second, third and AVF, and a reciprocal ST depression in lateral leads, means first, AVL and V6, which represents the inferior wall MI, means inferior wall myocardial infarction. If we see more closely, the ST segment elevation in third lead is more than second lead, and there is ST segment elevation in V1 and V2, the anterior leads, which represents right ventricular infarction. Okay. So if we give sublingual nitrates in this patient, there will be a sudden drop in blood pressure. For the reason, let's see some important points regarding the ECG and right ventricular MI. The point is, RV infarction complicates 40% of inferior ST elevation MIs. Okay, so the suggestive features we can see is ST elevation in V1, the only lead that look directly at the right ventricle. And the second is ST elevation in third is more than second lead, as the third lead is more rightward facing. So the diagnosis can be conferred with the right sided leads also. So what is happening is these patients are preload sensitive and may have an exaggerated hypotensive response to nitrates. In the treatment prospect, O2 should be administered and aspirin is essential in the management of patients with suspected ST-MI and is effective across the entire spectrum of MI or coronary artery syndromes. With the loading dose, we can give injectable low molecular weight heparin 0.6 subcutaneously. Therapy with the nitrate should be avoided in this patient as there is clinical suspicion of RV infarction. Okay, and the rest of the protocol will be depend on the availability of PCI intervention hospital. Okay.